Okay, that was works then. All right. Okay, everybody. Let's get started. So, welcome to the Epidemiology Seminar. It is my distinct pleasure to introduce today's speaker, who is one of the most well-known epidemiologists in our field. And so we are very, very lucky that he has agreed to come and join us today, Professor Noel Weiss from the University of Washington in Seattle. Professor Weiss used to be the chair, actually, for 10 years of the Department of Epidemiology in Seattle, and he is a professor there now. And he got his medical training at Stanford University. I should mention that most of his undergraduate studies were actually done at UCLA, so it's a homecoming for him because he also grew up in LA. I noticed that last night when he was telling the driver all the side streets to use, and I was like, why does he know his way around here? You know, why does he know Wilshire Boulevard and everything? And then he turned out to be from LA. Anyway, so he went on to Stanford for his medical training, and he got his doctorate in epidemiology from the Harvard School of Public Health. Professor Weiss went on to a very illustrious career in epidemiology, publishing more than 700 papers, writing several textbooks in methods in clinical epidemiology, and you may have actually perused some of his books. He's also the recipient of multiple awards. Pretty much every award in epidemiology that's given has been given to Professor Weiss. And he's been very distinguished in epidemiologic methods above everything else. So I think he's very well known for that. So he will share with us today his thoughts on personalized prevention, which I think is a very hot topic. We are moving from personalized medicine to personalized prevention opportunities, and many people are very interested in that. So thank you so much for joining us today, Noel, and we look very much forward to your talk.
It's great to be here. I was pleased to receive the invitation, especially because I'm now in my mid-70s and, often looking for younger blood to give these talks. But it reminds me of a story from when I was your age. I was an assistant professor 40-some years ago at the University of Washington, and we were paid a visit by a man named John Gordon. And he had been the chair at the Harvard of Epidemiology at the Harvard School of Public Health a long time ago, even a long time before I'm talking about here, the 1970s. And so long ago that I had never met him, even though I was a student there. He'd long since left. Anyway, by the time he got to Seattle, he was 85. And he gave the worst lecture I ever heard. It was disorganized, not comprehensible. And I'm walking back to my office alongside the then oldest faculty member, who Roger would know, John Fox. Nobody else will know who that is. And John said to me, I hope when I'm that age I can do that well. And I kind of look at him aghast. And then he continues. He says, I hope I have the good enough sense not to try. After this lecture, if you felt that maybe I don't have enough sense, that you please let me know, because I don't think I'm going to know it myself. We're going to talk about personalized prevention, but we're really going to focus on the other part, the second part, what findings are needed to support this. And just to get us started, it's pretty clear that there's some eagerness to get on the personalized bandwagon, that we're seeing all the time people, scientists, trying to make their findings more, quote, relevant, end quote, by focusing on the potential for personalized prevention. And I'll give you a couple of examples that I think we can all agree are kind of stretched. So this one is from you already know what my public health alumni magazine came from. It's from Harvard. They quoted a faculty member who had a study that observed a 10 to 20% increase in coronary heart disease incidence among persons with type A, B, or AB blood. That was the finding, and then in the magazine, the person went on to talk about this and said, well, don't worry, if you have one of these other blood types, you can reduce the risk by eating right, exercising, and not smoking. Now notice that first part of the sentence, if you know you're at higher risk. What if you don't know if you're at higher risk? Not a bad idea to follow that same admonition. In other words, there's nothing personalized whatsoever about the findings of his study. And it's again, it's just an effort to hype the results. Here's a similar example. It's from the Lancet. There's a 30% increase in stroke incidence among persons who worked more than 49 hours per week. Nobody in this room, of course. And what do the authors recommend? More attention should be paid to management of vascular risk factors in individuals who work long hours. Well, again, not a bad idea on any of us. We don't, no matter how much we work. The last example, this is among women who experience intimate partner violence and who become pregnant, 2.6 times more likely to smoke than other pregnant women. So taking that, if they're going now for, well, if you find a woman who's pregnant and smokes, maybe she's one who's got a higher risk of intimate partner violence. And so the recommendation is targeted intimate partner violence assessment of women who smoke during pregnancy may prove especially beneficial. And it might, but it doesn't mean that we couldn't do this for every pregnant woman. It's not that arduous and expensive an intervention. Okay. Let's start out by making sure we acknowledge there really are circumstances in which a given intervention aimed at the prevention of disease or death is appropriate. There are instances, and I'll give you one right here. This is an issuance from the 8th Joint National Committee, which makes recommendations with respect to hypertension management. And they suggest that one of the treatments, an ACE inhibitor, as first-line treatment might be for high blood pressure, might be reasonable for whites, but not for blacks. And they had very clear reasons for making that recommendation. First, blood pressure reductions among users of ACE inhibitors are only seen in whites. And indeed, there are randomized trials that included both whites and blacks, and only in the whites was there efficacy against cardiovascular disease endpoints that was similar to the efficacy for other antihypertensive agents. So this is the kind of thing that you might keep in mind when we're talking about personalized prevention. We want to know if there are some individuals in the population who do or don't benefit from a particular intervention designed to prevent adverse outcomes. Next example is another clear instance. So we're talking now about carotid endarterectomy. That's the carotid artery, the removal of atherosclerosis from there. People sometimes get symptoms from this, and so the recommendation is a possible surgical treatment for this. A study was done to look at the degree of reduction of risk of, now it says ipsilateral ischemic stroke. Everybody knows what a stroke is. Ipsilateral means on the same side as with the occlusion, and ischemic means due to a clot, not to a hemorrhage. So we're looking at two years, the risk of ipsilateral ischemic stroke, and everybody in this study had carotid occlusion, and they looked at comparing surgery versus no surgery. Sorry, I'm getting this confused. This is a surgical study comparing surgery versus no surgery, and they're looking at the benefit associated with surgery according to both age and the level of stenosis. So the top group, 70-99%, that's the group with the maximum stenosis. Only at most 30% of the lumen would be available for the blood flow. And if you're over the age of 75 and over, there's an absolute reduction of 28.9 per 100, which is really pretty large. You can reduce the incidence of stroke by that much. Indeed, for everybody with that level of stenosis, even if you're under 65 years, you're still getting a benefit of reduction in risk of 9.7 per 100 patients. There certainly is some morbidity and even mortality associated with doing the carotid endarterectomy, but that level of benefit would exceed the harms easily. If you go down to the bottom, on the other hand, get people who have a much lesser degree of stenosis, less than 50%. Now, while there is still some benefit in the older people, over 75, 7.3 per 100 reduction, the benefit down to the people of lower ages is really close to zero, and certainly within within the null, given the sample size in this study. So I think it's a pretty clear lesson here in terms of personalized prevention of ipsilateral ischemic stroke. Very heavily depends on degree of stenosis and to some extent also on age. You'd recommend the surgery only for some people and not for others. But just by documenting a difference in disease or mortality occurrence across segments of the population, that's not enough for making a differential recommendation, and why. And so this is the thrust of the talk coming up in the next few minutes. A difference in incidence does not necessarily indicate that in absolute terms, the benefit of an intervention will correspondingly differ. So what do we mean by that? Let's give you a hypothetical example here. And let's go back to our type O blood. So at the top we have type O blood and other. That's the A, B, and AB blood types. CVD stands for cardiovascular disease, and we're talking about cigarette smoking. And we want to know whether selectively people who have blood types other than O would benefit from stopping smoking. And the first thing we can notice is that in the group of people who don't smoke, here, you see there's the difference, underlying difference in incidence. It is higher by that 20% we saw in the very first slide, 12 per thousand over some period of time, as opposed to 10 per thousand in the people with type O blood. Now among the smokers, let's just say, again, these are made-up data, that the incidence of in the people with other blood types in the smokers is 22 per thousand. In the persons with type O blood, it's 20 per thousand, and that's a attributable. AR stands for attributable risk of 10 per thousand in both groups. In other words, it could well be that the impact of the intervention, the smoking cessation, could in absolute terms be the same, irrespective of how high the underlying risk was. And simply by knowing that the 12 is higher than the 10 doesn't guarantee that the impact of the smoking is going to be higher in the group with the underlying higher incidence. We actually have to study it. In this case, we would say, well, the impact of smoking is just as beneficial in both groups. Now, even if there is an absolute difference in incidence, it still might not be wise to recommend selective intervention. And here are the reasons. It could be that, yes, there's a difference, but it really doesn't make much difference. It also, and combined with, it may be that the cost of the intervention is on the small side, so we can apply it to everybody without worrying about it, who's at higher benefit. And finally, if the condition in question is a serious one, we may particularly be cautious about depriving some members of the population of an intervention that can have a favorable impact on their risk. So here's a very specific example. Helical CT screening. I don't know what the word helical means exactly, but CT screening is a very sensitive means of identifying lung cancers in people who are asymptomatic. And there have been randomized trials. A large American study identified about a 20% reduction in lung cancer mortality among people assigned at random to receive, I think it's annual screening for 4 years or something like that. But that study was conducted in people who were at underlying high risk on the basis of their cigarette smoking. And the reason that recommendations were made pertaining to smokers and not non-smokers is not because there were any non-smokers in that study that they could even evaluate, but rather the magnitude of the benefit would almost certainly be larger in the smokers, since in non-smokers the incidence of lung cancer is pretty low. And second, this screening doesn't come without a cost. The intervention itself, the cost of the helical CT screening, is pretty substantial. But the main problem is the number of false positives, that there are all sorts of, that the CT scan is so, it's very sensitive, but it's also not all that specific for lung cancer. It picks up all sorts of things, many of which have to be evaluated by biopsies. So it's not an intervention that you'd want to undertake in a low-risk population. So the recommendation, now people might argue, well, the recommendation, I believe, was something like, sorry, let's forget the recommendation. In the trial itself, the American trial, it was restricted to people who were current smokers or had been smokers but had stopped in the last 15 years. But then there are other people, other former smokers, they stopped 20 years ago, 30 years ago. What about them? They're still at a small increased risk of lung cancer, but the recommendation so far has not been to include them, but it's a close call. I think the call may switch a little bit in the future. I saw just within the last month the results of yet another randomized trial of the same question. They also used CT scanning, but they used it in such a way, this is a study done in the Netherlands and in Belgium, where they could estimate somehow the volume of the lesion. And based on that, they had very high sensitivity, but it seemed like they also had a lot more specificity, not so many of these false positives as had been present in the American study. And if that type of CT screening and the interpretation of those results takes hold, it could well be that the number of people, the range of people who would be viewed as, quote, eligible, end quote, for CT screening for lung cancer could enlarge to include not just smokers in the last 15 years, but maybe smokers at any point in time. The point I'm trying to make is that undoubtedly this is a preventive measure that will never be recommended for everybody. It'll be personalized largely on the basis of their cigarette smoking history. Maybe if we only knew about genetics that influence lung cancer to more than a tiny degree, that could be incorporated too, but I think maybe I could be corrected, but I think we're still waiting for identification of genetic characteristics that make a material impact on risk of lung cancer. Hope I didn't overstate that. Any questions up to this point? Yeah, please.
More troublesome is that we don't indicate when people lived in air-polluted areas, because the risk for air pollution is a 10 times higher risk for lung cancer as is for smoking. So that's the thing that is missing, not the genetics, which doesn't play a role for lung cancer as far as we know.
Yeah, I'm not myself I wouldn't call myself an expert on lung cancer epidemiology, and I think there are settings in which air pollution can play a role. I've never seen a study which identified anything close to a tenfold increase from air pollution. It's
well, we looked at it in Berlin versus Schleswig-Holstein, rural area versus cities. Mm-hmm. Tenfold risk if you smoke, 100-fold risk. What we have seen is that
okay.
In the action.
Well, I guess I should see that study. Certainly, studies more in the U.S. maybe with the contrast is less flagrant. Don't find anything quite that large. Thank you. Okay, so we've talked about this. But having said, under the circumstance of the for the helical CT screening, why there might be good reason to be selective in persons to whom it's recommended. This is not going to be true necessarily for this example. If somebody has type O blood, or if they work less than 40 hours per week, we're not going to say, oh, you can keep smoking. The decision to stop smoking is going to be almost certainly unrelated to those characteristics. I want to give you just a couple more examples where, even though there's an underlying difference in risk, the recommendations have been made to not personalize preventive measures. Think about bicycle helmets. Teenager compared to a 50-year-old, teenager has a much higher underlying likelihood of having a head trauma from bicycle riding. But yet, nobody would recommend, I wouldn't recommend that the 50-year-old can safely avoid using a bicycle helmet. The intervention doesn't cost that much, and the magnitude of the benefit is almost certainly large enough to justify. It's my understanding that the recommendation is for rotavirus vaccine to be administered to all kids in the United States, or all babies, I guess, in the United States. rotavirus diarrhea is far more common in Africa than the United States, and certainly it's advisable for African babies to receive this. But just because U.S. babies have a lower risk doesn't mean it's low enough that you can avoid the rotavirus immunization. So yet another example where, yes, there could be underlying differences in incidence of the problem, but personalized prevention, focus on the high-risk group, may just not be appropriate. Again, unlike the CT screening example. A few more points to make. Sometimes we want to, epidemiologists are like this, we worry about person time and not just persons. Here's an example. Breast cancer screening for women at average risk, 2015 guideline from the American Cancer Society, and I don't think it's changed since then. They recommend screening mammography every other year among most women. Most is capitalized, and we'll say why in the next slide. But the reason they made the recommendation for every other year as opposed to more often is that it turns out there aren't many interval cancers found by mammography within 2 years after a negative screen. And programs, there have been programs, randomized trials, where they had an every 2-year policy and an every 1-year policy, and the degree of mortality reduction from breast cancer was very similar in those kinds of trials. So that's what's underlying their recommendation. But again, this is for women 55 years and above, except if the woman's life expectancy is less than 10 years. Because the mortality reduction from mammography isn't occurring right now or next year, it's a ways off, and if the woman's unlikely to be alive at that point, why should she put up with the cost of the mammography, and especially with the cost of the false positives, which occur all very commonly with screening mammography. We're sticking with this person time notion because not every author seems to be aware of this, that it can be important. I'm going to quote you from an article in the Journal of the National Cancer Institute. It says CRC stands for colorectal cancer. We found that patients with colorectal cancer were statistically significantly more likely to develop diabetes than persons without colorectal cancer. Our study suggests that active screening and counseling may be warranted in this high-risk group. Well, wait, these people have cancer, and it's a serious cancer. If diabetes is going to take a mortality and toll on them, it's not going to be for a while, at most. And so my next slide is, don't these patients have more pressing things to deal with? Maybe once you get down the road, people seem to be maybe cured of their colorectal cancer. Maybe that would be a good time to worry about diabetes. But in the short run, you want to keep in mind that there are other things going on in life than you want to impose screening tests on them. Another point, let's see, which way am I going here? This is more of a editorial kind of point, what you should or shouldn't include in an article. If you're going to be writing about an intervention measure that conceivably could be applied to only some segments of the population, to what extent should your article be making such a recommendation? It says here that a recommendation regarding avoidance of exposure or adoption of an intervention says generally should not be made in an article that describes the results of the individual study. And it gives a citation. It happens to be an article of mine, but I'm not original with this idea. This is a commonly expressed idea. The bottom line is that it's all we can do in our own studies to document the means by which we did the study, to talk about the limitations, and to present the results in a clearest way as possible. And the idea that we would go beyond that to try to weigh all the risks and benefits of personalized prevention based on that particular measure, it's usually well beyond the scope of the article, and if we try it, we're just going to do an incomplete job, and people probably shouldn't pay attention to that anyway. Save it for the editorialist or the person writing a summary. So anyway, the point here is that these people writing about ABO blood type and heart disease, let them document that and not to worry about who should or shouldn't pay attention to blood type when making recommendations regarding management of other risk factors. So I'm saying the same admonition, I think it's appropriate. The answer to this question is yes. The same admonition is appropriate for potentially differential impact of an exposure or intervention on health. Now, I have a kind of a bit of an extended example here, but that will be the end of the talk, and so we'll have time for questions after we complete this example. And it says caution, because it turns out that there are many instances in which it's uncertain whether the impact of a preventive intervention differs across groups of individuals. Any of you in your epidemiology classes have long learned that when you're looking for effect modification, effect measure modification, that it can be tricky sometimes to figure out whether it's present or not. There could be a suggestion of it, but on which scale? And how large is the sample size? Is it big enough to be able to judge in terms of statistical accuracy what the impact is in the differential subgroups? So this is not going to be an uncommon notion, but I'm introducing it here in a very specific example that comes close to home. And the example is going to be, if you have atrial fibrillation, most of you know, it's an irregular heartbeat, not coming from the ventricles, coming from the atria, and as such, it's not the same life-threatening importance as ventricular arrhythmias. But nonetheless, it's a problem because people with atrial fibrillation have an increased risk of clot formation, which can lead to strokes, among other things. And so the example here, does the reduced incidence of stroke produced by anticoagulation, a common treatment among people with atrial fibrillation, does it differ according to the severity of the atrial fibrillation? Now, the reason this comes close to home is that I have this decision to make as to what I should do. I've had atrial fibrillation on and off for about 20 years now, actually. Mostly off, thankfully. I'm not in atrial fibrillation now, don't worry. But fortunately, there was published, it looks like 2013, here are the data. There was a randomized trial looking at stroke incidence in patients with atrial fibrillation, and the intervention measures, there was an active group in both. One was aspirin, because that's a commonly used drug in people with potential coagulation problems. But then the other one was something called apixaban, which is one of these new anticoagulants. Unlike warfarin, it doesn't require careful titration. It doesn't require repeated visits to the hematologist office. It's a very nice drug, except for the fact that it costs a lot of money. Anyway, you notice here in this, there are different types of atrial fibrillation, and that's going to be the point. There are people who are in atrial fibrillation all the time, and that's the permanent group, the bottom group. There are people who are in atrial fibrillation almost not at all. For this study's purpose, it was like less than a couple of days per year. That's my category. And then there's this intermediate group, persistent, which they have it often but not permanently. And you can see in the aspirin arm of this trial, the incidence of stroke is very different in those three groups. Well, it's similar in the persistent and the permanent group, but in the paroxysmal group, it's kind of low. Well, low in relative terms. 1.5% is 1.5 per 100 per year is still an appreciable incidence. Well, how about apixaban then? And you can see that in those persistent and the permanent groups, the incidence was dropped tremendously, from 3 to 3.5 down to 1.2 or 1.4 per 100 per year. In the paroxysmal group, well, it's still about that 1.3 per 100, but that's not much different than the aspirin group, the 1.5. And statistically, there's no difference between the 1.3 and the 1.5. But we're going to ask the question, is apixaban effective in reducing the incidence of stroke in persons with paroxysmal? That's the paroxysmal, remember, that's the top group where the difference is only 0.2 per 100. And there are several reasons to answer the question yes. The overall relative risk associated with apixaban across all three categories of atrial fibrillation, the overall relative risk is 0.45, and the p-value for heterogeneity of the relative risk is 0.23. Well, that's not too small. There's no, at least in relative terms, there's no statistical support, or not strong statistical support, for a true difference across the three categories of atrial fibrillation. Indeed, when you look at the lower 95% confidence interval of the relative risk associated with apixaban among persons with paroxysmal atrial fibrillation, it's all the way down to 0.38. In other words, going back to that slide, oops, let's go back up here. Where am I? The lower 95% confidence interval of that ratio of 1.3 to 1.5 is 0.38, which is pretty close to the magnitude of the benefit in the other two atrial fibrillation categories. And there wasn't any clear basis for expecting that the relative benefit of anticoagulation ought to differ depending on the type of atrial fibrillation. I talked to my cardiologist. He's of the opinion that, well, you know, everybody with atrial fibrillation is at an increased risk. He doesn't think it's necessarily due to the fact that some people are actually in it a lot. He doesn't have a clear basis, and so his recommendation would be to, you know, go take the anticoagulant. It's a very reasonable recommendation, but there are arguments on the other side as well. First of all, that relative risk associated with apixaban use in the paroxysmal group, which is 0.86, is a very wide confidence interval and certainly generously includes the null value of 1. And this is the most important point, the next one, let's assume that there truly is a benefit associated with apixaban use in people with paroxysmal atrial fibrillation. In absolute terms, it's pretty small. Again, going back to our table. The difference now, instead of 2 per 100 per year, it's 0.2, 10 times less. Well, if there were no harm associated with apixaban use other than its enormous cost, maybe you'd still think the difference of 0.2 per 100 is important. But there is some potential harm. Anticoagulants, especially the ones that are a lot more strong than aspirin, can cause bleeding. You know, in this same study, I'm not showing you the data on bleeding, but there are more bleeding complications in the apixaban group than in the aspirin group. But the magnitude of those is not so large. It's in roughly about 0.2 per 100 per year. So it's a close call. I decided I tentatively decided, these decisions are never permanent, that as long as I stay in the paroxysmal category, I'm going to stick with aspirin. I've been taking aspirin for quite a while. Partly because, as people who know me would say, I'm a creature of habit, don't like to upset the routine. It's partly because the evidence is not so strong, you know, that I don't want to rock the boat. I'm not saying it's going to be the right decision, and I have already told myself, and as well as the cardiologist, that if I ever switch from paroxysmal to one of those other categories, the next day I'm going to be looking for apixaban to get started. But for the time being, I'm happy. And so we get to the final slide, not second to last slide. The moral is that, yes, for those of us who are generating the data, and I'll put my patient hat away and put my epidemiologist hat back on, for those of us who are trying to generate the data, if personalized prevention is possible, really we can do the best we can to provide a valid assessment, realizing that the interpretation of those results may not be straightforward. Well, that's not new. I think it occurs in regular old epidemiology as well, all too often. If you want to read more, I wrote this article and it's published there. So with that, I'll stop. I'd be delighted to hear your examples or answer any questions. Thank you. Please.
Thank you very much for the talk. I'm wondering if you, the example you just gave with the anticoagulants is really comes down to sort of a additive scale or multiplicative scale issue. And I'm wondering if you've seen, if you have a preferred scale, or if you've seen like public health practitioners prefer the additive and clinicians prefer the multiplicative, and sort of how you weigh those decisions and thinking about personalized prevention. Is that a clinical issue or a public health issue?
Happily, the clinician and the public health practitioner would be in a complete agreement on this, is they are always looking to see in absolute terms how much impact, for good or for ill, is associated with a given measure. So there's no question about it. It's the attributable risk or attributable benefit, the risk difference, rate difference. That's the one everybody's going to be focusing on. Who deals with the relative risk? I mean, I love relative risk for a different purpose. When I try to judge whether, one of the guidelines for causal inference is supported, I'm looking for big relative risk or really small relative risk to suggest protection. But once I've done that, I put that aside. I've already used the relative risk for all it's capable of. Now, when I want to see how important is it in practical terms, whether it's for taking care of a patient or taking care of a population, the only thing I'm interested in is attributable risk. And I will say, happily, there are many changes have occurred in my all too many years as an epidemiologist, but one of them is the increasing recognition, especially by the clinical area, that attributable risk is the more important thing. And sometimes, almost to excess, that's all you'll see. And I'm still waiting. Where's the relative risk? They're so focused on the practical terms that that's all you see. But so anyway, that's a simple answer to your question. Yeah, please.
Yeah, thank you for this interesting talk. I think your example with AFib was a poignant one because it staged the patient by pre-existing condition and severity of that. And what I want to mention here in our group of epidemiologists is that most of our cohort studies, I'm not talking clinical trials, cohort studies do not contribute to that knowledge because we exclude sick people from the get-go. Our incident cohorts are usually people who are healthy and we are only looking at incident cases rather than a progression. In my experience in cardiovascular houses, like in your example, the people who are suffering the risks are mostly those who have already some cardiovascular disease. To a certain extent, you can measure it by intima media thickness or by prior angina pectoris or whatever that is. Most of the risk factors I've studied are much stronger in this group than in the healthy subgroup, and we always miss them nearly in the other group. So that
Thank you. No, that's very interesting. That's one of the, there have been over the decades more and more cohort studies with a cardiovascular orientation that will do at the baseline exactly what you're referring to, looking for intimal media thickness, the various tests to try to document the prevalence of the conditions, and that allows them, which would have been impossible without those measurements, to do exactly what you're saying, to see if there are subgroups who maybe already have some preclinical condition that are particularly sensitive to this. That's a good point. Anything else? Please.
So you started your talk with a quote in a university magazine from a researcher talking about, why does this association between blood type and I think the CVD matter? One thing I wonder is what they actually said in the article and what they said in a press release, and what's kind of the line that you've chosen to walk in terms of when you're approached by the press and thinking about our research is funded by federal dollars, we should be communicating our research, but you're often kind of pushed to stretch much further than you want about why it matters, and kind of, do you have any guidance on how you've handled that personally?
Well, yeah, I mean, I'm never shy about talking to the press, and I do think it's important for us to try to present our findings in ways that people other than epidemiologists can also understand. But we have to realize that the people who are getting the information from us, they have their own agendas. I can promise you that the Harvard Alumni Magazine is not unique in its tendency to hype and overblow the findings of the research. It certainly happens at my institution. And so when that happens, I insist, okay, you can write this up. I'm going to see it before it goes out, because I just don't trust them. And to some extent, that's going to be true of the news media as well. They call it news. The word "new" is in there. They're looking for new things. Usually, the new things aren't really the most relevant. It's the aggregate information that's available, but they don't seem to care about that. So you have to do your best as much as you can as an individual scientist to try to and convey to them the importance of not overhyping what's the newest thing that's coming out. It's a fine line. Yeah.
You mentioned it's a little bit along the line of the question that Elizabeth Rose asked. How do you interpret the findings, for example, of an attributable risk? We know that the attributable risk, the contribution doesn't add up to 100% necessarily. You can have, can go to much more. So theoretically, we really don't know what 30% attributable risk or something like that means. Only when we get into case numbers do we get it, right? But maybe you can say a little bit more about that.
Yeah, well, the most important thing I'm going to say is that for those of you in the room who weren't aware of this, the term attributable risk can mean different things to different people. When I used it, I meant literally like the risk difference. But there are many people, when they use attributable risk, will use it just the way you did, which is a percent. So when you hear that term, attributable risk, never assume that you know what the person's talking about. Always check out, is it Weiss and his risk difference, or it's the other version with the percent. The point made about the percents is completely accurate, that attributable risk percents can add up to more than one, because it may be that there are several factors could be acting together in the causal pathway. If you block one, you can completely prevent the disease from occurring. You block the other, you can prevent the disease from occurring. But by acting on both doesn't mean you can prevent the disease twice. You can only prevent it once. So that's how that can occur. But no, I was talking about risk differences. But thank you. If nothing else, thanks for your attention. I'm sorry, one more question.
If we still have time,
I'm delighted.
No, I think you are pointing to such an important area. And one thing which I noticed when we get into individual counseling, I have been a clinician before I became an epidemiologist. I witnessed something, an experiment we did at our university in Hamburg when we did counseling for pregnant mothers who had birth defects with one child and came in, what can I do? And one of the things which was the most successful program, I think, at our whole university was the toxicologist counseling. Because what they did, they said, here is 10 factors you can avoid. Don't go with your stroke. Don't walk the street where there's lots of traffic. Don't breathe all these carcinogens there, or mutagens in this case. Do this and do this. Don't smoke. The combination of factors to observe, even though they are tiny, when you combine them, they might interact with each other, which we don't study much, might give you a huge effect. How could we get this into our reporting? Usually we report on one factor. I would like to have some guidance.
Well, let's just say that I've never seen an instance where we were able to satisfactorily identify a 10-factor interaction. But armed with large enough data sets, they're getting bigger and bigger. There's a hope. One of the other I had proposed some other possible lectures, and one of the ones I proposed was going to involve at least a three-way interaction that was only studyable by using some gigantic data set. It turned out to be very important. I would argue that in the instance you mentioned, though, there could be another particular benefit in making those recommendations, and that is, if you made those recommendations to a woman who never before had a problem with pregnancy, she may say, oh, big deal, I'm not going to do it. But this woman is going to be very sensitive and might particularly adhere to what you're recommending. Yes. So there could be that advantage. Yeah, please, Rock.
Does this idea of personalized medicine or prevention get too close to the idea of Jeffrey Rose? I don't know if you're familiar with him. The idea of two prevention strategies, one treating the high-risk population and the other one the general population. Does this idea get into any of this?
Yeah, it does. Jeffrey Rose is an epidemiologist even older than me. I don't think he's not alive anymore. But he had this idea that he basically felt that you could do better by intervening on the whole population, even though on average there was a lower risk that whole population was at lower risk than a small population at high risk. And he had the idea that if that population at high risk was pretty small and it cost a lot to identify them, it just may not be worth as much. You may not get as much benefit in terms of disease prevention as if you were able to apply a simple intervention to the whole of the population. I don't view this as a kind of a one or the other. There will be in some instances, like water fluoridation, where it's good for everybody. And there will be other instances, like maybe helical CT screening, whether you really want to focus on that segment of the populations at particularly high risk. Like a lot of other things in epidemiology, the answer to the question is it depends. And you want to, and that's another important lesson for you guys. Don't be dogmatic. There are other factors that bear on that decision. Okay, now we'll stop. Thank you. Yeah, nice.
It was nice.
Yeah,
I'm
thank you.
Nicholas Krauss.
Okay, I've never met you before.
No, I haven't.
Are you relatively new to the faculty?
I'm had a secondary appointment here. I'm in
Okay.
the H&S.
Okay,
why
that's
I bring all
right.
these environmental things.
Good. I appreciate it.
But, these studies about the lung cancer have been, have been of course observational.
Yeah, sure.
But really, the risk is like that tenfold.
Well, yeah, I guess in some areas, right, with a particular kind of contaminant, I guess it's certainly possible. I just hadn't been familiar with it. Thank you.
And I think the tendency in our epidemiology is going so much towards individualized in terms of behavioral change or medicalization, and away from the other risk factors. And I see a little bit of a danger.
No, I agree, and it's certainly the problem tends to be, I mean, to measure and to quantify the impact of those more broadly acting substances usually requires ecologic studies. They have less, they're not precise as the individual studies, but you're right. When it's present, when they are present, then the potential benefit is tremendous.
It might change a little bit. Me getting now into more individualized sensors.
Oh yes.
They get more low cost.
Right. That would help.
Can measure many things at the same time.
Yeah.
So maybe that helps a little bit.
There's a whole research world out there that I'll probably never see.
And not the big data that comes with it. Well, good. Thank you very much.
Thank you. Same.
It's good to talk. Yeah, good to see you again.
Thank you.
I don't know if you're going to be here the entire...
No, I'm going to leave very soon. I'm going to meet a meeting with Roger Diesels. I'm going to go home. It's been very enjoyable. This morning I had a nice time with 6 students hearing about their work.
Yeah.
Because you're working with one of them. I can't remember which one now.
Okay.
They mentioned you.
Okay, wonderful. Yeah. This is Fabian Porter. He's working with Elizabeth Rose.
Oh, also. Oh, you're a postdoc.
Yeah.
From where?
I come from the field of neuroscience, actually. I'm interested in medicine.
Oh, I see.
But so
you're a refugee. So we've had a lot of refugees in epidemiology who brought with them a lot of knowledge that we otherwise wouldn't have.
That's right. Yeah.
Welcome.
Well, thanks again.
Sure. Thank you.
Oh, you're welcome. Somebody already knows.
It's so funny that the back is taped off. Right. Well, and he taped it off. I think that's so funny. I love it. That's not me.
Just have less and less.
Tolerance. Yeah. Well, and I'm sure that you decided to teach 20-plus-year-olds for a reason.
Yeah, I don't like kids. I really don't. We talk about that all the time. Like, my husband works in children.
Oh, okay, yeah.
I do not.
I'm not a children person either.
I'm like my baby. But I don't really like other people kids.
That's how my mom always was too. Like, she had me when she was pretty old. She's like, I never wanted kids. Didn't really like them. Would hang out with my nieces and nephews. That was good.
Right. And not too long with that either.
Do you what? Oh, you got something to plug in? Okay. I'm gonna hit the bathroom real quick.
Okay.